Hold up.
Hello everyone, welcome to another nursing video, and this time let's talk about critical care nursing. It is sometimes called critical care nursing, intensive care nursing, intensive therapy nursing. This is a field of nursing which focuses on taking care of patients who needs intensive monitoring, may it be they are from surgery or they had injury or accidents or even life-threatening illnesses. And critical care has its own sub-specialization depending on the specialization of your hospital. May it be renal, cardio or cardiothoracic, spinal or neuro ICU. It could be liver ICU, pediatric ICU, neonatal ICU, and many more. I am a critical care nurse here in the UK, here in London. But back in the Philippines, I am a registered nurse. Since 2009, I had a medical surgical background, and then afterwards I specialized to renal nursing. So I also had experience in renal dialysis or hemodialysis and even peritoneal dialysis. And then I was hired here in the UK last 2015, and I am so happy I had the opportunity to work in a critical care unit. So for you to be able to become an ICU nurse, there are various qualifications and requirements for you to pursue this career. Number one, you need to be a registered nurse or a qualified nurse. You have to have your license or your PIN duly registered to a regulating body. Here in the UK, we call it the Nursing and Midwifery Council. You must have also experience in medical or surgical nursing, and also you have to have these very keen observation skills, or what we call the critical thinking skills, because you have to think quick and you have to be very careful of all the decisions you have to make in your nursing interventions while you are working in ICU. It's not a one-man show, so you are also closely working with your nurse in charge, with the doctors and consultants, with the specialists, with the nursing specialists as well, with the dietitians, pharmacists, physiotherapists, and other multidisciplinary team that aims to improve the condition of the patient while they are in ICU. The usual routine when you work in ICU is starting from the handover. There are some hospitals who do their morning circle first or their evening circle first with a nurse in charge, or just to give you the overview of the entire census of the unit. And at the same time, you are allocated with a certain patient or patients, because in ICU, you can work either 1:1 or 1:2. It depends on the hospital policy, but mostly you are expected to take care of one patient, especially if this is a level 3 patient. We get the handover from the outgoing nurses from night shift or day shift. I usually do bedside checks after the handover. You also have to check whether the oxygen is working, if the alarm bells are working, because in case of emergency, you have to press the alarm. You also have to check whether the lighting is efficient, the ventilation is efficient, because that adds to the comfort and safety. Usually, other units have their bedside checklists for you to be able to be guided on what to check during your quick bedside checks, because that is important for you to be able to work safely for your patient. And also, in case of emergencies, you don't have to rattle yourself going in and out of the room or the bed space because you've lacked this and that. Risk assessments are necessary for you to be able to anticipate events that would happen while you are in your shift. Say for example, if the patient is prone or high risk for falling, if the patient is restless or disorientated, you have to do your fall risk assessment. If your patient is high risk on developing pressure ulcers, so you have to do your Waterlow scoring or your pressure ulcer risk assessment. After your risk assessment, you can now proceed to your head-to-toe assessment. You do check for the airway, the breathing, the circulation, the disability of the patient, the exposure, the lines, the laboratory, and all that. With airway assessment, you have to check if your patient is self-ventilating or dependent on mechanical ventilation. You have to assess the patient is breathing normally, regular, or dyspneic, or having some shortness of breath. You have to auscultate or listen to the chest if the chest sound is noisy. The main thing and the main point with that is know how is your patient breathing. If the patient needs support on breathing, needs supplemental oxygen, is the airway patent, is the airway not obstructed, does your patient needs suctioning, or is your patient comfortable in breathing? After your airway assessment and breathing assessment, you go to your circulation or the circulatory system. Usually you do check if your patient is warm and well perfused. Is there any active bleeding or drains actively bleeding or wound actively bleeding? Is your patient's blood pressure supported with inotropes or unsupported, meaning it's their own blood pressure? Is your patient's heart rate in a normal sinus rhythm or having some arrhythmias or abnormal heart rhythms? Is your patient spiking temperature or has a fever? And you also have to check the laboratories of the patient because you will see if the electrolytes are deranged. You have to top it up, optimize the necessary electrolytes because these will affect on the healing process of the patient. Do you need to do some ECGs in comparison to the previous ECGs done from the previous shifts? Are there any changes on the rate, on the rhythm of the heart? Like if the patient's having inotropes, what kind of inotrope, what kind of concentration, how much is the patient receiving? Because these affects the circulation process of the patient. So after doing the circulation, we can proceed with your disability assessment. I usually do this to check the neurological status of the patient. Is the patient confused? Is the patient disorientated or orientated? Is the patient alert, awake? Is the patient comfortable? Is the patient in pain? If he is in pain, what kind of pain relief is he receiving? Is the pain triggered by movement, or is the pain even intense even just if he is at rest? Where's the location of the pain? How painful it is? You can range it from 1 to 3. Easier to do pain assessment by 1, 2, and 3. 3 at the most. 2 is bearable. 1 is just triggered by movement but manageable, and 0 is no pain. You also need to assess if the patient is receiving patient-controlled analgesia or epidural infusion, because these may affect the mobility or the blood pressure of the patient, the heart rate of the patient, or even the consciousness of the patient, because too much of these controlled medicines can make your patients drowsy. So you have to check with that. You also have to check the patient's mobility. Can the patient move on his own? Can the patient move with minimal assistance? Can the patient walk towards the loo or the toilet? Will the patient need mobility aids such as a cane or Zimmer frame? If the patient is not able to move or bedbound, what type of equipment will be used for the patient to be transferred? Do we need to use hoist? Is it gonna be full hoist or the standing hoist? In terms of patient's elimination, does the patient need to be assisted going to the commode or to the toilet, or is the patient on a complete bed rest that just needs bedpan? We also check for the diet of the patient. Is the patient kneel by mouth or not allowed to eat and drink? It may be because of a pending surgery or a condition that doesn't permit to have any oral intake, or the patient can have full diet. Or what kind of diet does the patient have? Is it gonna be full diet, light diet, clear fluids, or free fluids, diabetic diet, renal diet? Is the patient allergic to any type of food and drugs? You have to check whether the patient is diabetic or insulin dependent. If yes, you have to check if the patient needs insulin prior to eating his or her meal. You have to recheck the blood sugar level from time to time, especially if the patient is on insulin infusion. You have to check because you have to titrate or increase or decrease the rate according to the sliding scale. So after disability, we usually assess the patient's exposure state or the exposure assessment. These includes lines connected to the patients. The patient has IJ or either left or right central lines, the vas cath. Is the arterial line working? Is the trace working? Is the trace proper or not? We also have to know if the patient has peripheral lines. You also have to check the integumentary system of the patient. Are the pressure areas intact? So we check if there are skin breaks or unnecessary or untoward skin breaks, because these are reportable incidences that warrants investigation or further investigations. Now, with assessment alone, you can develop so many nursing problems or potential problems that are really necessary for you to address within your shift, or if not, you have to escalate it to the nurse in charge or to the doctor for you to be able to prevent it from happening or reduce any significant injury that would happen to the patient because of a thorough nursing assessment has been done. So that's the story of my job being a critical care nurse or intensive care unit nurse. So I hope you like this video. If you have some comments and suggestions, you can just write it on the comment box. So thank you for watching this video. I hope you like it. If you like it, press the like button. At the same time, subscribe, and don't forget to be always positive and be happy. So see you on the next adventure. Bye!